enter the joint during while doing arthroscopy. See, as ma'am told, it's a steep learning curve, but still, once you are thorough with the process, once you know how to enter, I'll tell you, after doing 30 arthroscopies, the 31st arthroscopy you'll be able to enter very nicely or very easily. So, not to worry, like, okay, if I've entered the joint and I'm not able to see or I'm not able to view inside, there are a lot of extravasation of the fluid outside, scope is not in position, but that's okay, completely fine. Nature heals itself. That's what I've learned during my mini residency. I'm sure ma'am and everyone have learned during the mini residency. So, today we'll be talking about all the levels of arthroscopy. We'll be talking about level 1, but let me just describe you the levels of arthroscopy. Level 1, wherein you do a single puncture arthroscopy, where Dr. Arjun have already shown that what all you can see, the sweeping of the scope in the joint, and then flushing the joint, doing debridement. Level 2, where you do the major operative work, that is called an operative arthroscopy. So where you do the triangulation with another portal, you enter in the joint and you do the meniscus reduction. You take off all the scuffing inside. You take off the adhesions. You can do dissections. And level 3, where you do a meniscopexy. So the arthroscopic viewpoint is, if you are watching me over here, I'm the end point, but the last row can see everyone, but the second row cannot see everyone. Okay, so all of you, if the people in the last row, they can see what I am doing, what the first benchers are doing, or what the middle benchers are doing. But the ones sitting on the first row cannot see what's happening behind. That's why all the successful people are backbenchers, if you know it. So arthroscopy, level 1, single puncture, where you enter with the arthroscope, put an outflow needle for the fluid to pass out, and do lysis, lavage, diagnostic sweep, and adenolysis. Now, how do you do an arthroscopy? I mean, under what anesthesia? Local anesthesia, the first. Then sedation, next. Third, G, general anesthesia. Then segmental anesthesia. Segmental anesthesia? No. All of us, we all are wrong. We do it under GA with intubation. I'll tell you why. So, rules of safe puncture. First of all, be safe while doing an arthroscopy. Why? Now, head position. Patient is in supine position with the head turns towards the opposite side. If you are doing arthroscopy on the right hand side, the patient's head should be turned on the left hand side in supine position. Recently, there are now articles, there are now case presentations where people have started, just because while we move our head, we rotate the head towards the opposite side, we might injure our cervical spine. I mean the cervical spine of the patient. So now, again, the case presentations have come up where the person arthroscopy is being done under lateral position. So what are the standard, what are the vital structures? Here you can see vein, artery, nerve, artery, vein, nerve. This is the wrong diagram. First, we encounter superficial temporal vein, then artery, and then the nerve. Then we have the transverse facial vessels, the parotid gland, and the facial artery. So we have to enter in here. Now, what is the other vital structure? That is the brain. The small part of glenoid fossa, 0.5 centimeter. If you are too hard in it, you might encounter entering the brain or CSF leak, what we are talking about. So, this is the thinnest point. We have to be very careful. We cannot just poke our sharp trocar inside or the scope inside, any instrument inside. We might fracture the glenoid fossa. So this is the point where our instruments are been directed to. The articular eminence or the posterior slope of articular eminence. Sequences, examination under anesthesia, landmarks, insufflation. While doing that, we'll see in the video. Landmarks, insufflation, trocar cannula puncture, backwash, scope entry, outflow, diagnostic sweep. First image I'll tell you. This is how we mark it. What do we call it? Hommune-Helsing line. So is it authentic? Will come up next. We'll discuss about it. Once, in one case I marked with the scale. In one case, I've just kept my finger and drawn where exactly I can find the joint. Okay. Now, I'm examining the joint under anesthesia. The patient is in supine position with the head rotated towards the opposite side. This is the left joint where we need to do an arthroscopy. Now, what is the correct one? Is this one correct? Is this correct? Or this finger was correct? This finger. Which hand was correct? The one where I'm pointing the point, the one where the pointer is. Because with this hand, you will just be able, you can just palpate the zygomatic arch. You won't know what is the direction of the condyle. As Sir has shown, Abhay Sir has shown in his presentations, the condylar directions are different. The shape of the condyles are different. The angulations of the condyle are different. So this is the correct way to examine. Move the joint, dislocate the joint, relocate the joint, move it from lateral to lateral. Next, then you see I'm marking it. Again, one more time. We are examining. Sorry. Okay, that's okay. No problem. We are examining, and then I'm using my finger. I've drawn the homunculus line, but I realize that it is not correct. So next, I placed my finger onto it, and then I asked for a pen and have marked the joint. Now my points were not correct from where I wanted to enter in exactly. So I palpated the joint once again. I felt the depression angulating towards the glenoid fossa, and then I marked it. And just 2 millimeters below this highest point, I will put a point from where my scope will enter in. So this is the first step of entering the joint. Next, insufflation. How will you see? You have to put the fluid in. Okay, the joint has to expand for your instruments to get in. If there is a tent, okay, and the tent is lying, the carpet is just lying there, you won't be able to enter it, or you have to crawl it inside, right? You might even tear, you might even hurt, or you might even dig the hole on the ground. So next, what you need to do is that you have to insufflate, fill in with the fluid. What is the fluid of choice? Saline and normal saline and RL. It depends on surgeon to surgeon. I prefer doing it under normal saline. Or first, let me just get the report of an individual. Insufflation. From where exactly the point from which I wanted to enter in joint is the same place where I enter with the needle. Now I can insufflate the joint from any point where I want to, but this was my initial arthroscopy. So I'm entering the joint. I'm looking for the posterior slope of the articular eminence. I'm not hitting the glenoid fossa. I'm taking time. I'm insufflating with RL. Then the backwash. I can see the fluid which I insufflated is coming out now. So that means I'm in the joint. So now I'm injecting. At least 3 to 5 ml of joint will be the fluid will be needed to insufflate. Once the pressure is created, high pressure is created, then I will release the needle. I will release the cuff. And you see, it comes back automatically. The cuff comes back automatically. The fluid again gets back rushed in the syringe. So I'm sure now I'm in fossa and I'm insufflating the joint thoroughly. Next. Next, entering the joint. So with the sharp trocar and the blunt trocar. We use the grasping motion, like how we hold a pen or this scalpel. We use the grasping motion, enter it with the sharp trocar first, take off the sharp trocar, put in the blunt trocar. So sharp trocar will go for at least 5 to 10 millimeters, hitting the zygomatic arch, and then in the slope direction, we'll just rub off the periosteum from the zygomatic arch and enter the joint with the blunt trocar. Then we'll attach the fluid with an IV line. We'll see if we are thoroughly in the joint. So we'll fill the fluid, we'll inject the fluid in the joint, and then you'll see a splash of fluid rushing out of it. So what you see over here, you can see a red color fluid has come out. With pressure. The inflammatory fluid has come out. The long-standing inflammation has come out. Congratulations, your arthroscopy is done, or your arthrocentesis is done over here. And next, we enter the joint with the scope. Then what we do? Next, we are passing the fluid. It will expand. It will expand all the tissues. So we want another portal from which the fluid will come out. So that is the outflow needle. And you can see of the amount of fluid that we've put in, all the fluid gets flushes out from the outflow needle. That is the second point. Your Holmgren Helsing lens, point B is the point from which the fluid will come out. Or you count it as 0.5 millimeter anterior and inferior to the joint, 7 millimeter anterior and inferior to the joint, or 10 millimeters anterior and inferior to the scope portal. I'm sorry, not the joint, the scope portal. Okay? And every outflow needle should not go in a cross direction, like pointing it towards the laterally or something. It should always go vertical inside. And then happy scoping. Perfectly, you'll be able to see all these 7 points, which Dr. Arjun has told, and Dr. Santosh will also explain you what are the 7 points that you view in arthroscopy. You can inject the medications, but not very routinely. Pathology is what sir has already told. And this is the second operative portal. There is no video, there is a video, but now we are short of time. But I'll tell you, it's a triangulation technique. If your scope is there on the skin with the mark at 25 millimeters, you will put a triangulation port vertically inside, right over the skin at 25 millimeters again. Then only you'll be able to see the working instrument in the joint.
Sir, in the previous slide, can you explain that picture?
Triangulation?
Yes.
Okay. Quickly, this is my finger, and I'm watching this wall. Okay, and I want to paint this wall. Okay, I have a rod here, and I'm watching this wall, and I want to paint this rod. So I'm putting it like this, and I'm entering vertical. This is a 30-degree scope. If I'm looking over here, actually my view is this picture. And I want to plane this picture, so I will enter vertical. Now, this is the limit. There is a curtain over here. There is an imaginary curtain over here. So if you are entering, and this distance is 5 meters, okay, then my triangulation, my working instrument should also enter with the distance of 5 meters. Okay, then only you will be able to watch that. You will be able to see that working instrument. If it is lesser, you won't be able to see. If it is more, you will poke the wall and you will enter inside. Okay?
See, let me just make it very clear. There are 3 levels of scopy. One is level 1 when you are only entering with the arthroscope and you have an outflow needle. This much is clear. Level 1 arthroscopy, you will be seeing all those 7 structures that Arjun has already shown us. Over, that is your level 1 arthroscopy. Level 2 is when you put another port. That is, you use your triangulation method and then you put another port and another instruments inside that, through which you can do manipulations inside the joint. That is your level 2. In that you can take a biopsy, you can do some movement, mobility of the disc, okay, stuff like that you can do. That is level 2. Level 3 is when you do an arthroscopic discopexy, wherein you will pull the disc and you will do a discopexy arthroscopically. But that is all detailed arthroscopy. Basically, this was to tell you, okay, this is the way to enter a joint with the arthroscope, do a level 1 and see these things. Are we clear so far? Details of level 2 and all is beyond this course.
So, is my time up? Okay. So this is the level 2 arthroscopy. Just a presentation, a picture presentation. Okay. So this is from how we enter it, as I've explained you. This is the working portal from which you, as you have seen in the picture, in the video of Dr. Sankar Mittal's presentation, that you can actually do a meniscus repositioning by holding the meniscus. This is exactly that point. You are there at the junction of retrodiscal tissue and disc, and then you are putting the meniscus again back over the top of the condyle. This is where you are doing adenolysis. This is my cecal knife through which I cut off the adhesions. Also, I use a biting scissor through which I do the adenolysis, or I cut off the thick adhesions. This is a sharp trocar, the initial entry, how we enter in the joint, and then we pull out the sharp trocar. We pull the sharp trocar out and we replace it with another instrument, that is the probe, through which we want to maneuver the joint, or we want to pull out the entire, it looks very dirty, you know, but that's okay, completely fine. This is how you do an arthroscopy. This is my working instrument. I want to push my meniscus back in position over the top of the condyle. I've taken out the probe and I'm cutting off the adhesions and pulling out the adhesions, and then again I've put my probe in. I put the probe in, I'm dissecting the lateral pterygoid tissue, and I'm putting the meniscus over the top of the condyle. I'm pulling the meniscus over the top of the condyle. Here you can see this. The meniscus is reduced over here, in this space. Yes. Ma'am, is my time up? Yes. Thank you.